Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier Education brought to you thanks to our sponsors, AstraZeneca, Medtronic, and Medina, the Science of Care. I'm Eric Lim, and this week it's a great delight for me to present Professor De Coppi, who is a professor of pediatric surgery at Great Ormond Street Hospital, to talk to us a little bit about his research and progress using decellularized hollow organs. Paolo, over to you.
Thank you very much, Eric. Thanks, Prof. Lim, the organizer, for this opportunity to present to you what has been the progress on making tissue engineering organs. This is my disclosing. I've always been fascinated by surgeons that have spent their time working between the laboratory and the patient, and I think we need as surgeons to be more and more involved into this process. And I'm fortunate enough to work in a place where this happens. And regenerative medicine is a reality in this ACR building at Great Ormond Street Hospital, where scientists and surgeons work shoulder to shoulder to try to make new organs. Which approach have we taken? Well, I start a bit from the end, so from the patient perspective. Here is Kieran. Kieran came to my attention in 2010 when he was 12, and he had undergone several operations by Martin Elliott, who was the head of cardiothoracic team at that time at Great Ormond Street Hospital, because he was born with a congenital trachea stenosis. So what happened is, as several stents after the first operation, one of the stents eroded through the trachea into the aorta and caused him to bleed. And the old trachea, which needed to be substituted, couldn't be done with conventional type of surgery. And therefore, we use the expertise that we're mature in the laboratory to decellularize a cadaveric trachea, seed it with the patient's own cells, and substitute the entire trachea. And at that time, also the aorta was patched. Importantly, the vascularization of the trachea was achieved by moving the omentum from the abdomen to the chest and wrapping the new trachea with the omentum. This is just a short video that summarizes that. So we took the cadaveric trachea and decellularized it through a process that is based on enzyme and chemistry, and allow us to build a scaffolding that was seated with the patient cells. Here is some part of the surgery. Most importantly, here, allow me to say that the stent was used that is a HeLa stent, is essentially PDS. We use it clinically, and this gives to the scaffold at the beginning the strength that is lost after decellularization. And here is Kieran, a few years later, playing his favorite instrument. And essentially, Kieran had his life back. And we know that with time, the trachea shrank. And here you see in the first 5 years how the trachea shrank, but allow him to have his life back. And he hasn't had any surgery since 2010. So it's 15 years past in March, and he has been able to survive with this trachea. I think it's important in our branch that we disclose the negative results, and we publish indeed the patient that subsequently, after Kieran, received a similar transplant but did not survive. So this patient was a much more complex surgical patient with a single lung. We substitute the trachea with an engineered trachea derived from cadaver. This patient survived well to the transplant, went to the local team, where during an endoscopy, the trachea was perforated and the child did not survive. So this is just to keep in mind how close you need to monitor those patients that undergo innovative therapy. So it took us quite a bit of time to do a third patient, which I'm sharing here today. This Valeria, she's a little child that unfortunately ingested one of the lithium battery and this lithium battery destroyed both the esophagus and the trachea. So we did a gastric pull-up, and subsequently the trachea, which was initially repaired by Mr. Mutialu with pericardial patch, that would be our first choice. This didn't hold. These lithium battery are really terrible caustic, and we recommend always, if you have children, to remove those lithium battery everywhere in the house. Essentially this trachea couldn't heal, and so we had to do again a trachea engineer, because that was the only way to repair that trachea. This was built in the laboratory, and we know with time we did not have a normal trachea. No, that's not what we are claiming, but had a trachea that initially needed a stent, as you see in the slides, but with time, Valeria became stent-free, and the trachea, while not being normal, allowed her to functionally work. And in fact, we noticed serial biopsies that we had a normal distribution of the cells with basal and apical cells differentiation. Valeria is doing really well, and again, is now 8 years past, and she never needed any further procedure. Where we are moving? Well, thanks to the people in the laboratory and the group coordinated by Colin and Rob, the trachea is taking the opportunity to work on different directions. So, for example, everybody knows about the devastation of epidermolysis bullosa, and the fact that some of the experiments have been done to substitute the skin on these children, but they still may have airway problem. So the idea is that you can take some cells from their airway, engineering them with a correction gene, and you can use a retrovirus that has been used in patient with a skin problem, or you can use a lentivirus, and you can engineer those cells to express the correct gene and put it back into the patient. That's the idea that has been tested in rabbits so far by the group coordinated by Rob, and these cells were primarily taken from rabbit, engineered with a transduce vector, and then substituting the epithelium on the trachea, and we could follow these cells. You can see some images of the fluorescence present in the trachea, and this was also detected at 10 days post-transplant, as you see here in the slide. So this is one way that we can take this experimentation and can be useful for children affected by genetic disease. But a few years ago, we reviewed the spectrum of regenerative medicine for the Lancet, and what makes a huge difference between good and bad experiments is the amount of research that is behind. So we need to remember as surgeons that we need to go deeper into science to protect our patient and to get faster to the patient rather than slower. So to not repeat what has happened with the plastic trachea, we need to understand very well the biology. So for example, now for the cornea replacement, you can take limbal stem cells from the other cornea and expand those cells and substitute the diseased cornea. And this has become the gold standard. Why? Because people know very well about limbal stem cells and how to grow those cells. But when we want to go to more complex tissues, we need to understand other problems. For example, vascularization. For the trachea, as I say, because of cartilage tissue, it's easy with a omental or other wrap to give enough vascular supply. But when you consider other tubes, other hollow organs, like the intestine, you need a proper vascular supply. So we've been working with Shai Rafi, an expert endothelial stem cell biologist at Cornell University in New York, to try to expand endothelial cells. So postnatal endothelial cells have a problem. They cannot be expanded. So we use a transcription factor called ETV2, which is expressed very early on the embryo and then shut down during the postnatal life. And by using this, we could expand the cells and making them in large number. And in fact, we could build network. So you see here an example of these cells building a network and the blood being perfused with no clotting and no extravasation. So that made us more prone to the idea that we could build a vascularized tissue in vitro and then transfer in vivo. And that's indeed what we did for the intestine, that we could really vascularize the intestine. And we could see that the endothelial cells were seated where previously endothelia was present, but washed out by the deserialization process. Well, can we then make a functional gut? Well, this is a big statement, but we've been working, thanks to a European grant, together with others, on making intestine for children with short bowel. What we do, we deserialize the intestine, maintaining all the structure of the intestine. And if you look at the electronic microscopy, you see villi and crypt there present. We use also this intestine to make gels. One of the problems of expanding stem cells is you have to use GMP compatible things. And for example, to expand organoids, that's not possible nowadays because you have to use matrigel, which is derived from a mouse tumor. So what we did was to take intestine from pig, decellularize, and create gels. One important message to us as surgeons is that the matrix is not an inert material, but it is actually clustered together with different organs. So for example, the lung and the intestinal matrices, because they are endoderm, they cluster very close together, but the brain and the muscle cluster very far away. And this is important because different collagens can give to different regeneration process. And for example, when we use decellularized matrices in our practice, we should take that in account. So with Vivian Lee at the Crick Institute, we were able to extract organoids from children with short bowel. We were able to expand those and create mini patch of intestine. And we know now that these mini patch have functions similar to the small bowel. So one idea in the future is to substitute, for example, the mucosa of the colon with the small intestinal mucosa. That would be extremely useful, first of all, because the colon is not so relevant as the small bowel, but also much easier than engineering the whole intestine, which was the initial idea. Well, are we any close to patient? Well, there's one disease, which is the esophageal atresia, would be familiar to the pediatric surgeon in the audience. But for the adult surgeon, this is a very rare condition in which the esophagus hasn't fully developed. And what we do nowadays is a thoracoscopic repair of the esophagus. When that is not possible, we need to do substitution. At our institution, thanks to Professor Spetz, the experience is with a gastric pull-up, which is a good substitution for the esophagus, but is not ideal, of course, for these children that have a good 80 or 90 years in front of them. So the idea is that beside the anastomosis and the stomach, we may have the opportunity for engineering esophagus. And I really have to thank a lot of people that over the years has helped us develop in this. And the idea is to take decellularized esophagus from pig and seed it with the patient own cells. So in the past 15 years or so, we've been working on this project, and along the line, we have learned how to decellularize esophagus in pig, how to engineer that in bioreactors that can give peristalsis and follow them with luciferase, for example. And you just see by putting on a bioreactor how you have a much thicker esophagus, which I'm sure the surgeons here will be much happier to anastomose. We also learned, for example, that you need fibroblasts there to make the muscle cells migrating. And in order to approach the patient, we have done the same experiment in pig that we would do in patient. So we're taking a biopsy from the recto abdominis because in patient we would do a gastrostomy, so we can take the biopsy directly from them without doing further procedure. We isolate the muscle and the fibroblast. We injected in the decellularized esophagus, and then through a thoracotomy, we did an orthotopic transplantation with a pleura wrap as to offer the vascularization to the esophagus. So importantly, the pig were able to grow without any NG tube or any gastrostomy. And we had to do endoscopies on these pigs. And this is just the appearance of the esophagus at the end of the 6 months. We could recognize only because of the stitch there and the stitch up here on the right that this the native esophagus that was, the engineered esophagus that we implanted, but didn't look much dissimilar to the rest of the esophagus. We know that these esophagus have given us some trouble that we see also clinically with the patient with esophageal atresia, and we'll be familiar with the esophageal surgeons in the audience like stricture, which were responding to dilatation and to stent. Independently from us, gastroenterologists and physiologists were able to identify peristalsis in these esophages, and in fact, this correlates to the fact that these pigs were eating normally. When we look at the histological appearance in the upper part, you see the graft esophagus, which is similar but not identical to the native one. Spatial transcriptomies give us the impression that the esophagus from left to right became more similar to the native, the one on the right. Of course, we are distinct from the native, but very similar to that. The last few slides I want to present with you is, can we do this even before birth? So the idea is that because we are getting so good at prenatal diagnosis, can we offer a therapy before? And this is already reality when we consider spina bifida. So spina bifida is a defect in the closure of the neurocord and the spine, which can now repair 25 weeks of gestation through the gold standard, which is an open in the uterus, which allow us to expose the plaque and close the defect in layer as you would do postnatally. However, we and others have developed methods to treat these prenatally, also with a fetoscope, so we can go once the uterus is exposed, and we've done in vitro simulation and animal studies before moving into human, and we can do the same repair in human. But also there's an opportunity there to take stem cells. So we described a few years ago about the possibility of getting stem cells from the amniotic fluid. Why the amniotic fluid? Because it's easy, accessible, and can be used for prenatal diagnosis. And we can take it all during the gestation and expand those cells. But particularly, there's a large proportion of epithelial cells and epithelial cells that come from different organs, and in particular, the one we were able to isolate and describe a year ago were from the lung, the intestine, and the kidney. And big credit goes to Mattia Gelli and his team that works in our group at UCL, and as focus his attentions to the cells, for example, derived from the lung. And so there are proximal lung differentiation with ciliated cells that can be differentiated, but also proximal and distal differentiation from the same cells, showing that they're really progenitors, like forming lamellar body. So this is the original paper. You can find all the details about the results there. But what opens up this research is really the possibility of deriving a functional prenatal diagnosis. So you can predict, for example, for organs like the lung that don't really work before birth, how those lungs will develop in the future, and describe for example, with assays, how they may work at birth. So the idea is what I showed you before, like the esophagus or the trachea, that could be engineered before birth and implanted either before or after. So in conclusion, stem cell and tissue engineering technology, I'm sure, will become very complementary to transplantation. I'm not here to say that all the problems have been solved. I think we have to approach as surgeon like a continuous problem solving approach with problems that are generated by our research rather than solved by our research. But I would like to leave with the message that regenerative medicine is a clinical reality and surgeons must definitely be involved earlier on. I couldn't be here presenting if it was not all the people in the laboratory that are working on this technology and the funder. I also would like to thank all my clinical colleagues, which are very instrumental to what we do every day. Thank you very much again to Professor Lin, and I will be happy to take any question. Thank you.
Thank you very much, Professor De Coppi. That's an amazing and outstanding presentation on where we are today. And congratulations on so much progress that your team has made leading this, across the world. Maybe I'll start with some questions. Can I ask, are the hollow organ transplantations or, decellularized transplantations expected to grow with the patient as the patient gets larger?
Yeah, that's a very good question. And yes, we know very little in patient, of course, because our experience is limited. But both for Valeria and for Kieran, we have observed a growth of the trachea during their lifespan. One is 8 years in patient, one is 15 years, and that was during puberty, so it was a big growth. Now, it's difficult to see what is due to the fact that the remaining trachea after the transplant is growing and what is the transplant itself growing. What we know is that there's a continued rebuilding by the body of the trachea we implanted, so the cells will not persist more than 3 months, the cells that we see there. So we know that remodeling is made by the body, and of course those new cells that come from the body will see their matrices. So at the end of the day, it gives a sort of a scaffolding to the body to rebuild the organ.
Excellent. And presumably these tissue engineered organs don't actually need any immunosuppression because the body doesn't reject it.
Yeah, that's a very important point, and just to remark that both patients that we know in the long term, that we follow up long term, never need any immunosuppressant drug, and that was the case from the beginning. So the fact that you strip out all the cells from the donor and you substitute it with the patient's own cells, that takes away completely the immunological problem.
Can I ask, for elective cases, how long typically would it take to generate a decellularized organ?
Yeah, it's 8 weeks. So a bit less probably now, but that's the safest time is 8 weeks.
And is it possible to use this technology in adults as well?
Yeah, so it is possible. My experience is limited to pediatrics, this technology or similar technology have been used in adults. You certainly are aware of the experience in Paris with the aorta decellularization, which is very similar in terms of the technology, in the sense that it's an organ decellularized. Certainly, it's very important to know that at the beginning you need a stent there, because after decellularization, the organ, particularly the trachea, which is a problem, becomes quite floppy and takes time to get back to the rigidity that it has initially. And so the stent is very crucial. But in children, certainly, we don't need any stent after 6 weeks or so.
And at the moment, to restore the vascular supply, I noticed that you're using the pleural wrap. Is that right?
Yeah, so for the trachea, we have used the omentum wrap. For the esophagus, we use the pleura wrap because the experiments in pigs. In children, we are pretty sure that we will still use the omentum. The omentum is a great resource for vascular supply, and it's very easy. I mean, my only contribution as a general surgeon was to do that. But to bring the omentum on the back of the sternum is very easy. There's a natural orifice there almost, and you can bring it through there and then wrap it around.
Right. There's a question from Dr. Tejlushko, who's asking about his patients with short intestinal syndrome after damage control surgery. And would there be any potential usage for your tissue engineered organs in this setting?
Yeah, absolutely. So I think in adult, certainly in children, but similarly in adult, when you have volvulus or you have other ischemia that damage mainly the small bowel. So those patients usually preserve their large bowel, but it's pretty useless because just control salt and water absorption. So yes, the technology we are developing and we are doing now in pigs, we and others, I must say, there's a big group in Japan coordinated by Dr. Sato, who is using organoids as well to replace the mucosa of the colon. And there's another group, Kim Jensen, in Copenhagen, and there's another big group in Cincinnati. So all these groups are working on the same technology, which now seems to be the most promising one, is to substitute the mucosa of the colon with mucosa of small intestine, because that will offer the best opportunity for these children and adults, because you don't need to rebuild the whole intestine, but you just need to patch the mucosa.
Dr. Mahmood and Dr. Theresa are asking the same question. What are the limits of tissue engineering? Is it limited to mainly hollow organs?
Yeah.
Or do you think at some stage it's going to progress to more complex organs like the kidney, the heart, the lung?
That's a very good question, and something that I'm quite convinced now that actually xenotransplant is more promising to more complex organ. I've been working on this technology now for more than 25 years, and while at the beginning we were very convinced that we could build even more complex organ like the heart, the kidney, and so on, I think nowadays we need to be a bit more realistic that when you have a vascular supply and a vascular network, xenotransplant are going to get faster to patient. I mean, we already seen the progress within the few years. They really have progressed so well, and I'm sure once some of the problem that are arising, of course, will be tackled, it will be a more promising technology, less costly, because this technology is very expensive. So I think the tissue engineering will be limited when part of a tissue or a whole organ, for example, that is very difficult to replace because the vascular supply and so on. When you have an esophagus, you cannot either you do an en bloc of various organs, but it's otherwise very difficult to transplant the xeno esophagus. I think for those, tissue engineering will still be very promising. For more complex organ, I'm afraid I'm very sorry to say that because it's what I invested so much time, but I think other technology would be superior.
Thank you. There's a question from Dr. Al Bulishi who's asking about in fetal surgery, if you are using, stem cells derived any tissue, is there a problem with maternal rejection of the tissue or fetal rejection?
Very good question. And actually, we know more and more about the maternal fetal immunology talk, if you want. And we know that it's the perfect transplant in the sense that you have two different individuals, they don't reject each other. So there's something happening earlier on in pregnancy that makes the individual tolerant. And of course, there's a barrier there, that is the placenta. So we know that some of the cells are trafficking earlier on from the mother and the fetus, and in both way, and these create a tolerance. So now this tolerance, if you use cells from the fetuses, will not create a problem. If you use a third cells, so a allogeneic to the fetus, then you can create a rejection. So As far as you use the fetal cells, the mother and the fetus will tolerate it.
Excellent. Thank you so much for like a mind-blowing presentation. I mean, you've really opened our eyes out here,
Thank
which
you.
just leaves me once again to thank our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. Next week, we're going to talk about diagnostic pathways for anterior mediastinal masses. Last but not least, once again, Paolo, thank you so much for your talk today, and congratulations on your research and for leading the world into this amazing advanced field.
Thank you. Thank you very much, Eric. Thank you, everyone, for the opportunity.
Bye-bye.
Bye. Bye-bye.